Welcome back, everyone. If you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. So, today we're diving into the absolute financial lifeblood of the hospital system. We're talking about the Inpatient Prospective Payment System, or IPPS. If you've ever found yourself wondering how on earth a massive hospital translates incredibly complex patient care into just a single, predictable reimbursement figure, well, you're in exactly the right place. We're going to explore the MSDRG system together, and you'll see exactly why clinical documentation is, quite literally, the foundation of healthcare revenue.
Okay, let's take a quick look at our roadmap for this explainer. First, we'll peek under the hood at the DRG payment engine. Then, we'll explore the MSDRG architecture and break down exactly how severity and multipliers work. After that, we'll tackle the strict gatekeeper of the whole system, the POA indicator, before we wrap things up with clinical documentation integrity and the super important world of audits and compliance.
All right, let's jump right in. Section 1, the DRG payment engine.
So what exactly is DRG anyway? Well, it stands for Diagnosis-Related Group. And at its core, it's really just a statistical system that classifies inpatient stays into groups that are expected to use a similar amount of resources. Think of it like a giant puzzle, where clinical similarity plus resource similarity equals one single payment group. Instead of cutting a check for every individual bandage, every single pill, or every hour of nursing time, Medicare and other payers use the DRG to hand over a single, fixed prospective payment for that patient's entire stay, and it's all determined right at discharge.
Now, this system wasn't just built overnight. The evolution is actually pretty fascinating. It started way back in the 1980s over at Yale University with the original DRG, which really just did some basic early grouping by the principal diagnosis. Then we got the APDRG, which brought in some broader pediatric and obstetric refinements, followed by the APDRG used by Medicaid, which introduced a cool 4-level severity scale. But the real game changer for Medicare, the one that completely revolutionized hospital billing, happened in fiscal year 2008. That's when CMS rolled out the MSDRG, or Medicare Severity DRG. This modern engine actually differentiates payment based on the specific severity of a patient's comorbidities.
Which brings us to Section 2, inside the MSDRG architecture.
So how does this actually work? The system uses a logic engine called the grouper. Medical coders basically feed ICD-10 codes into the software. But here's the kicker. Not all inputs are created equal. The grouper looks at the principal diagnosis, secondary diagnoses, procedures, and patient demographics like age, sex, and discharge status. But the absolutely critical takeaway here is that principal diagnosis. That's the condition determined after study to be chiefly responsible for admitting the patient. And guess what? It drives a massive 80% of the DRG assignment. If that principal diagnosis is off, the entire payment structure is just built on a faulty foundation.
Okay, so the grouper processes all these inputs in a really logical 3-step hierarchy. Step 1, it assigns the case to one of 25 major diagnostic categories, or MDCs. These are essentially just body systems, like MDC-05 for the circulatory system. Step 2, it partitions the case into either medical or surgical. The rule here is super straightforward. If there's a major operating room procedure, it goes surgical. If not, medical. And finally, Step 3, it assigns the DRG triplet based on severity.
Let's look closer at that severity piece in Section 3, Severity, CCs and MCCs.
Now, what's really interesting here is how the MSDRG system categorizes secondary diagnoses. It pulls from a massive list of over 14,000 codes that are considered either a CC, that's a complication or comorbidity, or an MCC, which is a major complication or comorbidity. The system uses 3 distinct payment tiers. If a patient's chart has even just one diagnosis flagged as an MCC, like, say, diabetic ketoacidosis, boom, it pushes the DRG into the absolute highest payment tier. If they only have a CC, it lands in the middle tier. And if they have neither, you guessed it, it drops down to the lowest payment tier.
And this right here perfectly illustrates why highly specific clinical documentation is absolutely everything. Just imagine a scenario where a patient is treated, but the discharge summary just vaguely says chest pain. There's no clear linkage there, which means you get an incorrect, lower-paying DRG, real revenue loss, and some serious compliance risk. Now, compare that to some really precise documentation, something like acute anterior wall MI managed with PCI to LAD. That gives the coders the exact principal diagnosis and procedure they need to assign the correct DRG. The clinical reality was exactly the same in both cases, but the words used literally changed the whole reimbursement picture.
To figure out the actual dollar amount, every single MSDRG is assigned what's called a relative weight.
An average standard case gets a weight of exactly 1.0. So if a hospital's base rate is $10,000, a DRG with a weight of 1.0 pays $10,000. But if poor documentation drags a case from an MCC tier with a weight of 1.9 down to a basic tier with a weight of 0.8, the hospital just lost thousands of dollars for care they absolutely provided. To put it simply, higher documented severity directly equals proportionally higher payment.
Moving on to Section 4, the crucial POA indicator.
POA stands for present on admission, and this is a big deal. Every single diagnosis code submitted must have a POA indicator attached to it. The rules are incredibly strict here. A Y indicates the condition was present at the exact time of inpatient admission, while an N means, you guessed it, it was not present. There are also a few specific flags for insufficient documentation, which is a U, clinically undetermined, which gets a W, and exempt conditions marked with a 1.
So why does this matter so much? It comes down to a strict policy from the Deficit Reduction Act. Let's say a patient is admitted for pneumonia, and a couple of days later, they develop a severe deep vein thrombosis, or DVT. Now, DVT is an MCC, but because it developed after they were admitted, it gets a POA flag of N. CMS considers this a hospital-acquired condition, or HAC, and the rule is absolute. An HAC cannot be used to increase the DRG payment tier. The system completely ignores that MCC for payment purposes. It halts the multiplier in its tracks and can even subject the hospital to a pretty intense quality review.
All right, let's shift gears slightly and talk about Section 5, Clinical Documentation Integrity.
You see, clinical coders aren't allowed to just guess what a doctor meant. They absolutely have to follow the written record. If a doctor jots down a vague term like respiratory failure, a CDI specialist will actually pause the billing clock and send a formal query. They'll ask something like, "Doctor, please clarify if the documented respiratory failure is acute, chronic, or both." Why go through all that trouble? Because acute on chronic is a really powerful MCC driver, whereas an unspecified term yields significantly less reimbursement. It's a huge difference.
And this brilliantly illustrates the CDI workflow, which is basically a highly structured 5-step collaborative bridge. First up, the CDI specialist reviews the chart while the patient is actually still admitted. Second, if they spot a gap, maybe a high lab value with no corresponding diagnosis, they generate a compliant non-leading query. Third, this routes straight into the physician's electronic health record inbox. Fourth, the physician responds and clarifies the note. And finally, in step 5, the coder uses that clarified documentation to finalize the MS-DRG, allowing the compliant claim to be released for billing. It's a really neat system when it works well.
Let's wrap things up with Section 6, Audits, Compliance, and Risks.
Hospitals have to maintain incredibly strict compliance to achieve what we call ethical optimization. It's a real balancing act. On one side, you have the severe legal danger of upcoding. That's assigning a higher-paying DRG than the documentation actually supports. Do that, and you trigger the False Claims Act, face aggressive OIG audits, and get hit with heavy overpayment penalties. But on the flip side is undercoding, where you fail to capture complex secondary diagnoses. This strands revenue, artificially lowers the hospital's case mix index, and essentially makes the facility look like it treats much less complex patients than it actually does. Neither is a good place to be.
To prevent both of these extremes, facilities rely heavily on rigorous audits. They use retrospective audits to catch errors after submission that might have caused denials. They also use prospective audits to review charts before the final coding even takes place. And then there are concurrent audits, which are real-time reviews done during the admission to validate those POA flags and capture CCs and MCCs immediately. Honestly, continuous monitoring is the only real way to ensure the integrity of the data.
So I want to leave you with this question to really chew on. Does your facility's clinical documentation truly reflect the exact severity and complexity of the care you provide? The MS-DRG system is a total marvel of data classification, but it's completely blind to the care provided if it isn't explicitly documented. Remember, precise words dictate the DRG dictates the relative weight, and that weight dictates your hospital's financial survival. If you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. Keep learning, keep optimizing, and I'll catch you in the next explainer.